Hello, everyone. I'm Nathan Sarzan, a pediatric intensivist at Texas Children's Hospital in Houston, Texas, United States of America. I'm part of an international group of pediatric intensive care doctors, nurses, nurse practitioners, and clinicians that put together the next series of videos showcasing pediatric intensive care units, or PICUs, in North America. It's important to recognize that pediatric critical care in North America evolved from the successes of our colleagues in neonatology, anesthesiology, surgery, and adult critical care to address the needs of children with life-threatening illnesses. As such, collaboration is ingrained in what we do. It is this essential trait that defines our units in North America and has allowed the field to experience tremendous growth in a relatively short period of time. While our first dedicated units opened in the early 1960s in North America, it wasn't until 1981 that pediatric critical care became recognized as a distinct medical subspecialty. Since then, things that were once impossible have become commonplace. We've seen our units grow in size, along with the development of sophisticated transport services that allow for improved access to care. We've seen technologic transformations that allow us to change outcomes. We've seen revolutions in surgical techniques that make once fatal conditions survivable. And most important, we are able to provide care that recognizes and embraces that our patients are still children, even if they are hospitalized in a PICU. None of this would be possible without the lifelong dedication of countless individuals, some of which you'll hear in the following videos. Thank you.
And I'm Eva Asangbedo. I'm a pediatric cardiac intensivist at University of Texas Southwestern Medical Center in Dallas, Texas. We hope that the following videos give you a glimpse into what a day is like in a pediatric intensive care unit. In these videos, you will hear from an amazing, incredible, and diverse group of people from across the United States and Canada, each working in a pediatric ICU. Each will describe their role in the ICU, their training and background, and most importantly, you will see how multidisciplinary collaboration allows us to do amazing things for our most critically ill and vulnerable pediatric patients. Allow me to introduce Dr. Sapna Kachepkar. She's a pediatric intensivist and anesthesiologist at Johns Hopkins Hospital in Baltimore, Maryland. She's the founder of the PICU Up program, and her research focuses on improving the outcomes for critically ill pediatric patients through early mobility and rehabilitation. She is the senior associate editor for the journal Pediatric Critical Care Medicine, and she created an online community for pediatric critical care globally through the hashtag PedsICU.
Hi, my name is Sapna Kachepkar, and I'm a pediatric critical care physician and anesthesiologist at the Johns Hopkins Hospital in Baltimore, Maryland. As a physician who works in the pediatric intensive care unit, also known as a pediatric intensivist, I care for infants, children, and adolescents who are recovering from major surgery and trauma, and children impacted by critical illness. To become a pediatric intensivist, I completed 4 years of medical school, 3 years of general pediatrics residency training, followed by 3 years of subspecialty training in pediatric critical care medicine. Working in the pediatric intensive care unit, or PICU, is incredibly rewarding for so many reasons. I have the opportunity to care for children and their families during a most stressful time in their lives in partnership with an incredible interprofessional team. The nurses, respiratory therapists, nurse practitioners, hospitalists, pharmacists, rehabilitation team, social workers, child life specialists. Each of these amazing colleagues are integral to providing the best care to critically ill children. And as a physician on that team, I learn something new each and every day from them. In addition to working with these PICU team members, pediatric intensivists collaborate daily with physicians across all specialties in the hospital in caring for patients with a wide spectrum of ages and diagnoses. There is no place in an entire hospital system with a more diverse patient population than the PICU, which requires a truly collaborative approach to care. If you walk into any PICU, you may see a 1-month-old infant next door to a 17-year-old teenager. In addition to providing outstanding clinical care, pediatric intensivists across the globe, like myself, are dedicated to advancing science in the field of pediatric critical care so we can improve both short and long-term outcomes for our little patients. It's my greatest honor to care for critically ill children in the pediatric intensive care unit each and every day.
Hi, we are Respiratory Therapists at Children's Healthcare of Atlanta.
Respiratory care is one of the most important aspects of pediatric critical care medicine. As a respiratory therapist, it is so rewarding to be an integral part of a patient's recovery.
As a respiratory therapist, we typically have a 3 to 4 year education in a respiratory therapy program from an accredited college. And then respiratory therapists practice in the intensive care units, in the emergency departments, in the general care areas, and in home care as well. Most of us have training in PALS and in BLS, and we maintain our skills through competencies and simulations.
Respiratory therapists in the PICU are responsible for optimizing oxygenation and ventilation. We do this through assessments and therapies directed towards respiratory function.
Respiratory therapists manage the patient's artificial airways, including endotracheal tubes and tracheostomies. And with physician collaboration, we help manage the sickest patients in the hospitals on mechanical ventilators.
As respiratory therapists, we work closely with the physicians and the medical staff to help improve lung functions of our sick patients. We start by using aerosol treatments with various medications, and then on top of that, we do chest physiotherapy, whether it's outside the chest with our hands or using machines. And then we suction the patient out with the suction catheter to remove the secretions.
We are also responsible for the management and delivery of other inhaled gases,
Such as Vero, which is our inhaled nitric oxide, our helium mixture mixed with oxygen, as well as isoflurane.
At Children's Healthcare of Atlanta, respiratory therapists get to participate in the ECMO program, where we take care of children on advanced life support.
Another part of my role is to help multidisciplinary teams with early mobility. We help mobilize patients that are intubated and non-intubated by helping them get up on the side of the bed or even walk around the unit.
We also work in managerial roles to aid in the system and development of best practices using quality improvement initiatives such as developing protocols, policies, and procedures.
Respiratory therapists work as educators in the hospital. Some respiratory therapists are classroom educators that teach knowledge-based information, and others teach in a simulation environment, like myself. This is a low technology mannequin, but we also use high technology mannequins, and we teach respiratory therapists, nurses, physicians, and also family members to ensure the best outcome for our patients.
One thing that I love about being a respiratory therapist is forming that intimate relationship with the patients and family, really developing a bond and being a part of their recovery.
I am Hallie Lenker. I'm a pediatric physical therapist and rehab team coordinator at Johns Hopkins Children's Center. As pediatric physical and occupational therapists, we work to promote safe early activity while working with the medical team and family to optimize a patient's development and mobility while in the pediatric ICU. I love working in the pediatric ICU as I get to help patients and families during their medical journey when they often have the least control.
Hi, my name is Trish Dillon, and I am a nurse here at Benioff Children's Hospital, Ucsf, a medical center in San Francisco, California. I've been here 34 years, very long time. I've done lots of different roles, and currently, in maybe my most passionate role is I'm the coordinator for the ECLS program. ECLS is extracorporeal life support, also known as ECMO. And here at Benioff Children's Hospital, there are 2 pediatric critical care units. There's a medical ICU and a cardiac ICU. And the pediatric ECLS program kind of covers both of those units. What this program is used for and what it entails are when pediatric patients come in and they are critically ill, and their heart or their lungs give out and are not working sufficiently to support their bodies, we will bring in this type of machine. This is the pump we use. It's called the CardioHelp. There are several different pumps that are used across the United States and across the world, but we use this particular pump. And this pump acts as artificial heart and also an artificial lung. So we attach the patient to this pump with big IVs, either through the neck or through an open chest. And blood is taken out of the patient. It runs through the pump where it's oxygenated, and there is a rotary or a centrifugal pump. That pump pushes the blood forward back into the patient. So it acts, as I said before, the heart and the lungs for the patient. Normally, this is a short-term type of therapy, and it's used for patients, maybe they've undergone cardiac surgery and they're not able to separate from the bypass machine, or children come in with horrible pneumonias and their lungs can't oxygenate adequately for their bodies. Some kids have horrible infections and are septic. Other kids and patients, or babies and teenagers, or their actual heart muscle itself becomes ill and can't function or can't pump blood adequately to all parts of the body, so we would put them on this machine. It's used for short-term therapy. Sometimes it's 1 or 2 days, sometimes it's a couple weeks. But during that time, it takes over the work of the heart and the lungs, and it lets the patient's body heal. And then once they're able to adequately oxygenate and provide a good cardiac output, we take them off this machine. It works beautifully. Patients, while they're on this, can be awake. We have families at the bedside. We have them participate in as much care as we can. And in the end, the best part about this whole program and this therapy is most of our patients are healed. They come off and they come back and see us, and they're walking down the hall, and it's just an amazing feeling to think about when they were in a bed hooked up to a heart-lung machine, and now they're coming in visiting, and it's probably the best part of my job. The other piece of my job that I really, really enjoy is the training piece. So nurses actually in our institution run this pump. Across the United States, sometimes perfusionists or sometimes respiratory therapists manage the pump itself, but in our institution we train expert cardiac and ICU nurses to run it. And the training program, it takes place over, there's 2 didactic days, and then they have 2 or 3 full-time shifts at the bedside. And they get trained with another experienced GCLS nurse, and then they're signed off and they care for the pump and they care for the patient. So that part is really fun and interesting. And the other piece that I like about it is it encompasses a whole multidisciplinary team. So we have physicians and fellows, respiratory therapists, and nurses, and the perfusionists all kind of work together. We have a meeting every morning where we discuss the patient's plan of the day, and can we come down on the support? Do we need to go up? It's definitely a group effort, and again, it's just an incredible feeling when these kids come back and visit us all. And it's something that we've done as a group, and we've helped kind of restore this patient and family to a good sense of health and a long life ahead.
Hello, my name is Brian Kelly, and I'm a pediatric clinical pharmacist at University of Florida Health Shands Hospital in Gainesville, Florida, which is in the United States. Today I'm going to talk to you about what a pediatric clinical pharmacist does in the pediatric intensive care unit. And so just briefly, how you get to become a clinical pharmacist. First of all, you go through 4 years of pharmacy school, and you obtain a Doctor of Pharmacy degree. And afterwards, if you want to work in the hospital setting, a lot of times to become a clinical pharmacist, you have to do extra training, which is called a pharmacy residency. And so usually these are 1 year in length. And so the first year residency, or a PGY1 residency, is kind of a general residency where you see multiple areas of pharmacy, whether it be transplantation, ICU, oncology, et cetera. And then some pharmacists will follow that up with a specialty. And so depending on the area that you want to work in, for example, myself, I work in pediatrics. It's usually, pediatrics is a whole specialty by itself. So second year residency in pediatrics exposes you to various areas of pediatrics, including pediatric intensive care unit, cardiac ICU, neonatal intensive care, et cetera. And so once you complete a second year residency in pediatrics, usually you can go and practice in various areas of pediatrics, or the area that you're interested in. And my interest was pediatric ICU. So what does a pediatric ICU pharmacist do in general? And so we work closely and collaboratively with other disciplines in the pediatric intensive care unit. And so this includes physicians, nurse practitioners, physician assistants, dietitians, respiratory therapists, case managers, nurses, etc. And so we round usually on a daily basis with the entire team. And so we make a lot of contributions, obviously regarding medications. And so there's a lot of things, usually once the prescribers prescribe a medication, usually through physician order entry, we're able to verify these medications so that they can be, obtained or used by the nurses and other disciplines. And so while we're verifying these orders, what we're doing is we're performing a lot of background checks. And so a lot of these include, is this an appropriate dose? Are there drug interactions? Are there certain side effects that we might need to be concerned about or warn the team about? And that's what, we help to try to bring to that. Some of the things we'll do, especially in ICU, there's a lot of patients receiving total parenteral nutrition, or TPN. And so we work closely with a lot of, especially our dietitians, to help write these TPNs as we're helping the prescribers. And in addition to some of these, daily functions, we also help with working closely with physician leadership in the ICU, as well as nursing leadership, to try to help come up with protocols, et cetera, that might be useful. So order sets and other safety and quality type of projects, we try to work on closely with them and try to, especially if there's anything related to pharmacy or medications in those order sets. So a lot of these things will include sedation order sets, et cetera, that, may be pretty helpful. And so then lastly, I just kind of want to, mention, how does this, apply to, or how does this benefit the patients? And so the way I feel like patients benefit from having a pharmacist on rounds is, one of the most important things is, I think we offer as, a second or a third check. So obviously we're there to try to help when physicians, are obviously looking for, either information about how to dose certain medications, especially in very complex diseases, where there's very little literature, especially in pediatrics. We offer that type of, expertise that, other places may not be able to have. And so we can work closely with them to, find out the literature that's there, and to try to help, make sure that there's appropriate safeguards for these patients and for these small children. And with that, I thank you for your time.
Hello, my name is Kelly Sheridan. I am a pediatric registered dietitian here at the University of Florida Shands Children's Hospital. Just some background about myself. I obtained my bachelor's degree at the University of Florida. In order to become a registered dietitian in the United States, you have to complete a bachelor's degree. Currently, that is changing in 2024 to master's degree eligible. Then we go through a supervised clinical practice, also called an internship. It takes about a year, and then you're able to sit for your license. I'm also a certified specialist in pediatric nutrition, which means that I have to show 2,000 hours of work in pediatrics in order to sit for that exam as well. That exam is only good for 5 years, so every 5 years I have to recertify. What is my role in the pediatric ICU? My role is to be the nutrition advocate for the patient. I work on rounds with the team every day, working with the pharmacy and the doctors in terms of writing TPN, writing enteral nutrition orders. Also work especially closely with our speech language pathologists and occupational therapists when it comes to advancing PO diets. We work with a lot of babies with special needs, and so I need to know, what is a safe texture for that infant to be able to consume. Other things that we are involved with in the ICU is research projects. We also recently were given the rights to have ORDI art RD order writing at our facility, and this has been great because we are now able to order those PO supplements, those oral nutrition supplements for the patient. This means we don't have to track down the physician to go order a Pediatric or a can of Ensure. We can just do that ourselves, or if we feel that we need to make an adjustment to an already existing enteral nutrition order. We also work closely with case management and social work in terms of discharge planning. How can I get that formula for that patient to go home with? So anything that we can do to speed up the discharge process, we try to help. Kind of what does the dietitian bring to patient care? I think my presence in the unit is the best thing that I can provide for patients. We come up with plans sometimes on a daily basis. The nurse or the doctor can come to me that day and say, this is working, this isn't working, and we can make an intervention at the moment, rather than waiting till the next day if my office was somewhere other than in the ICU. Parents can have access to me if they have questions about a nutrition plan, how are they going to go home with this plan, how is it going to work for their life. So I think that's the best thing that I can do, is kind of just being there and being that advocate for the patient. It was great to get to know you. Thank you very much.
Hi, my name is Leah Carr, and I am a pediatric intensive care nurse at the University of Michigan Health. I've been a nurse for 15 years, all of which have been in pediatrics. A day in our pediatric intensive care for me looks like leaving my children, who don't always want me to leave for work, to come to the building where I take care of other people's children. Arriving in the parking structure, driving around for 10 minutes to find a parking spot, walking in. Now it's a pandemic, there's a security clearance at each entrance and a health check. Waiting on the elevators, which can now only serve 4 people, and so sometimes a few elevators go by before we are able to get up to our unit. Once I arrive on the unit, we get a brief report of all of the patients on the unit before selecting our assignment, and once the assignments are selected, we go to the bedside. We get a bedside report from the previous shift nurse, which usually lasts about 25 to 30 minutes. And giving all of the details of the patient's care, what's been going on and what to prepare for in the future. My most important assessment skill at that point in time is often just listening. The open-ended questions of, what does the goal look like for the night for you? As a night shift nurse, ensuring my patients sleep and rest is always at the top of my list, because I think that we need to do that in order to heal. I need to establish a relationship with the family and assess their understanding of both what medically is going on with their child, and also what their experience level is with healthcare and previous healthcare experiences, so that I can tailor my conversations with them and my education for them to give them the opportunity to fully feel comfortable asking questions of the whole team, and also knowing that they are an important voice in their child's care.
How does the collaboration with all aspects of a medical team play a role?
I'm very fortunate to work in an ICU where collaboration from many specialties is key and is ongoing. Personally, I work the night shift, and so I am not there at the bedside when the physical therapy and occupational therapy visits the patients, but with their detailed instructions, I'm able to do an exercise with the patient at night, or I'm able to place splints and braces properly. Our respiratory therapists in our PICU are beyond amazing. Our collaboration with them is vital. They are crucial, as well as our nurse practitioners and our physicians and our clerks and our nurse techs and our environmental service team. Everyone who sets foot in the PICU is involved in making sure that the patient receives the best care. Yes, there are interventions of, assessing all of the lines and drains and tubes, and placing lines and drains and tubes, and But the most important interventions are my assessment and also the relationship that I establish with the family. The family is the patient's best advocate in the ICU, and in order to fully understand who my patient is, I need to establish a relationship with the family as well. As a nurse of 15 years, frequently on our unit, I'm also in the role of either charge nurse or the role of initiating CRT therapy if needed. There's often times where I'm precepting new staff, ensuring that I pass my knowledge and education and experience along to the next generation of PICU nurses. Those nights when I have to do all of my thinking that I usually do in my head out loud and convey it to the next nurse, those are the hardest and most rewarding nights when I see the new nurse understand the complexity and the incredible advocacy that we as PICU nurses can have for our patients. I love that no two nights are the same.
What does holistic nursing care mean to you?
To me, holistic nursing care is looking at every piece of the patient, the way their previous experience with healthcare interacts with their current experience, the way their vital signs interact with their skin, the way their emotions interact with their heart rate. It's looking at the entire patient and placing all of them together so that you're not seeing bits and pieces of a person and you're not seeing just the disease process, but you're seeing the entire person and caring for the entire person.
Hello, I am Dr. Yonca Bulut. I am one of the pediatric ICU physicians here at UCLA Untitled Children's Hospital. And today our focus will be child life and importance of child life at ICU.
Hi, my name is Megan Pike. I'm a member of the Chase Child Life program here at Ronald Reagan UCLA Medical Center. As a certified child life specialist, my job is to help ensure that patients thrive emotionally as well as medically while they're here at our hospital.
Certified child life specialists are professional healthcare providers who work alongside of and in support of the multidisciplinary team to help reduce traumatic experiences and to increase a child's ability to cope with what's going on in the hospital. We do this by bringing opportunities for play and for normal childhood experiences to the critical care setting. We look for opportunities for empowerment and for developmentally appropriate ways of helping children to understand their illness and their hospitalization. In the PICU, children undergo a lot of invasive medical procedures. Child life specialists can use a variety of targeted techniques to help reduce the fear associated with these. Many times, these psychosocial interventions can decrease or even in some cases eliminate the need for procedural sedation or anxiolytic medication. As Dr. Balut and our PICU staff have reminded us many times, sickness is not stillness. And that motto is never more appropriate than when it applies to children. Children need to move their bodies to feel like themselves again. So whether it's their first time up in a chair after an organ transplant, or a new parent trying to navigate tummy time with tubes and wires, we offer encouragement and innovative ideas to support early, appropriate mobility in the critical care environment. Here at UCLA, we really benefit from our many different partners who help bring joy and healing to our pediatric patients. A particularly popular program is our volunteer people-animal connection, in which our volunteers with approved pet dogs get to visit patients at bedside. When the COVID-19 crisis hit, the Child Life program was ready to help. We use video conferencing to facilitate socialization. We offer remote consultation for families at home, and we continue to provide in-person interventions at the bedside utilizing appropriate PPE and infection prevention protocols. The Chase Child Life program is incredibly lucky to include professionally credentialed music therapists who work directly with our patients and families. Music therapy in critical care uses specifically designed music-based interventions to address a patient's and a family's many different needs.
Tomorrow will be kinder. It's true, I've seen it before. A brighter day is coming my way. Yes, tomorrow will be kinder.
Despite the best efforts of the critical care team, sometimes children in our care do not survive. And for families facing the death of a child in the PICU, a child life specialist can help. We work together with the family and with the medical team to create moments for togetherness and for making memories. We work with siblings to help them understand and to say goodbye in ways that are meaningful to them. While nothing can prepare a family for the loss of a child, we hope to help families begin their grief process with support, with honesty, and with a wholehearted recognition for the life of their child.
I'm Victor. I'm one of the social workers at Children's Healthcare, and I work in the PICU. We work to help families through the good, the bad, and the ugly. We work with the rest of our family support services staff, our chaplain, our child life specialist, case managers, and others to figure out what the family needs, what we can do to help them while they're here, and to think about what they might need on the way out after discharge. So that can be anything as simple as providing some help with meals, or it can be all the way to if a patient passes away, we provide bereavement support to them as much as we possibly can.
I am Jafania Cotton, nurse case manager at the Ecls campus in the PICU. I have worked with Children's Healthcare of Atlanta for 17 years, first as a nurse. In the past 5 years, I have been a nurse case manager. The nurse case manager serves as a patient advocate by assessing, planning, implementing, monitoring, and evaluating proactively to anticipate the patient's needs. The nurse case manager identifies the patient's discharge needs and communicates with the physician, patient, and their families in order to establish a specific plan of action that promotes quality of care and patient outcomes. This helps the patient and the families to understand their health status and treatment options while ensuring the patient receives the assistance necessary to follow through with their personal plan of care. The success of these efforts are enhanced by working collaboratively with the physicians, the advanced practice practitioners, the nurses, social workers, and other members of the interdisciplinary team. The nurse case manager also transitions patients to the appropriate level of care. As needed, we arrange transfers to enter facilities, out-of-state, inpatient psych facilities, and to inpatient rehab centers. We obtain prior authorizations for medications given in the home and collaborate with the pharmacy benefit managers, insurance companies to ensure that the patient receives essential medications needed at discharge. We arrange home infusions, enteral supplies, durable medical equipment, skilled nursing visits, private duty nursing, and outpatient physical therapy. We also work with the oncology teams, medically complex, cystic fibrosis, and the outpatient to provide disease management for their care. The nurse case manager ensures the patient's needs are identified and by providing a seamless transition from the hospital to the home.
Hi, greetings from Houston. My name is Nate Sheridan. I'm a pediatric intensivist at Texas Children's Hospital, and I have the privilege of introducing you to some of the most important frontline workers that we have. That would be our pediatric residents, our pediatric advanced practice providers, and then also our pediatric critical care fellows.
Hi everybody, my name is Nawara Alawa. I'm a third-year categorical pediatrics resident at the Baylor College of Medicine and Texas Children's Hospital, and I'm here to tell you a little bit about what it's like to be a resident in the PICU. I think my experience in the PICU was so unique because it's really the only place in the hospital where we have such a multidisciplinary approach to taking care of our patients. I feel like I'm constantly interfacing with my amazing bedside nurses, my RTs, my physical, occupational, and speech therapists, and of course our wonderful child life teams. It's also a really unique opportunity to learn how to take care of critically ill children and their families who are going through probably the roughest times in their life. I have absolutely loved my experience working in the PICU, so much so that I've chosen to go into critical care, and I'm starting my fellowship in July. I really find the PICU to be such a unique place and such an opportunity for learning and taking care of really amazing children and their families through the toughest times in their life.
My name is Emily Tolson, and I'm a nurse practitioner in the pediatric ICU at Texas Children's Hospital. My education to become a nurse practitioner consisted of 4 years of a bachelor's degree in nursing, and then after working for a couple years as a nurse in the pediatric ICU, I went to graduate school to get my doctorate in acute care pediatrics, and then took a board certification test to become a pediatric acute care nurse practitioner. I think when I think of collaboration, specifically at Texas Children's Hospital, we're a very large institution, and we're fortunate enough to have a lot of physicians and nurse practitioners and PAs serving in some of our subspecialty departments. So we have a great opportunity to collaborate with a lot of people regarding patient care. In addition to just having a large number of subspecialties, a lot of the people that work here as medical providers come from a varying degree of backgrounds. They're from all over the world. And I think that adds a really wonderful kind of unique perspective when we talk about patient care. And that's one of my favorite parts about the job, I think, is that we get to be in kind of the unique position to bring everyone to the table on behalf of the child and make sure that we're doing everything we can in their best interest.
My name is Tommy Fraze, and I'm a physician assistant in pediatric critical care at Texas Children's Hospital and Baylor College of Medicine. To become a physician assistant, I went to 4 years of undergraduate training to get a Bachelor's of Science degree, and then I did an additional 2.5 years of training to get a Master's of Science and to earn my physician assistant certification. When I think about my role in the PICU as a frontline provider and collaborating with other people that work in the PICU, I feel like our role is perfectly suited for collaborating. As a frontline provider, we're always in constant contact with the other healthcare professionals that work in the PICU, most frequently nurses, respiratory therapists, we have physical therapists, occupational therapists, our attendings, our fellows, everybody. We sort of serve as like an intermediary between everybody to help coordinate the care for the patient. And amongst ourselves, we do a lot of the coordination, but we also coordinate and collaborate a lot with other consulting services that are helping us care for the patients to provide them the best care. So I feel like our role as frontline providers, and specifically as a PA, really allows me to collaborate with all of the different people that work in the PICU to produce the best outcomes for all the patients that we take care of.
Hi, my name is Katie Doan. I'm a pediatric critical care fellow here at Baylor College of Medicine, Texas Children's Hospital in Houston, Texas. Prior to fellowship, I completed 4 years of college, 4 years of medical school, 3 years of pediatric residency, and I will complete 3 years of pediatric critical care fellowship this June. As fellows, we help diagnose and treat our critically ill patients here in our large pediatric ICU. In addition to the fellows that we have stationed in each of our cohorted PICUs, we also have an administrative fellow who helps collaborate with all of the teams to complete any tasks that are needed so that our primary teams can continue rounding and taking care of the other patients. We also respond to rapid responses on the floors and codes anywhere in our hospital.
Hi guys, I'm Alina Wong, and I'm a pediatric intensive care unit nurse and a palliative care nurse. And I currently work at Ucsf, Benioff Children's Hospital. So part of my role is on the IP3 team, which is the Ucsf Integrated Pediatric Pain and Palliative Care team. And our role here at the hospital is to help families and patients going through serious illness. We are a team of multiple providers with various backgrounds. We're nurses, we're social workers, chaplains, physicians, massage therapists, active therapists, music therapists, child life specialists, you name it. And our role is really to help families through this very challenging and uncertain time in the hospital and throughout the trajectory of their illness. And so I have the passion and the opportunity to be able to guide parents through this journey. I have for example, sometimes we get to take families out into this beautiful, beautiful Zen garden out here where they can meditate, have time to themselves, some space to think and reflect on everything that's been going on for them. As a bedside PICU nurse, I have the unique opportunity to really spend this time building space with them. Even when times are chaotic at the bedside in the intensive care unit, I like to find those moments to really just hold space, be quiet, and listen to their hopes and their worries about the child. And I really find that really empowering.
Hi there, my name is Mary Alice Gallen. I am the VAD coordinator for the heart failure team at Ucsf Benioff. And my role basically is to do management, troubleshooting, and patient clinical support for the nurses who care for our patients. So my role is to be the person who pretty much manages the ventricular assist devices, also known as artificial hearts. So we have 3 types based on the conditions and the patient age and the patient weight that we use. The first one I'm going to show you is Berlin heart. Now this device, and this is our smallest Berlin heart, sits outside the body, and so we call it a paracorporeal device. It sits out the body and is hooked to a pneumatic device that pulsates, and it basically acts as the heart. The second device we use, and this is a bigger one, so it comes in many different sizes, but this is the smallest pediatric, and this would be the largest pediatric. The next device we use this is more considered a temporary device. This is called the Centromag, or on the babies called the PediMag. We use this if we think a child is only going to need support for a couple weeks. We also would use it on a child who's smaller than we can use this for. So we say under about 4 or 5 kilos, we would use this to support them, which also can be done long term. And then the one implantable device that we use is implanted right into the left ventricle, apex of the left ventricle. A graft is placed up to the aorta, and this is hooked into a small little controller, I'd say about 4 inches long, 4 inches wide, and they carry that around. And these kids can go home. These 2 devices, they cannot go home. So as far as what I do, I come in the morning, I will pre-round on the patients, look at their labs, look at anything that's gone on overnight, talk to the nurses. We'll round on the patients. We will then go to any planning that we need to have. We'll make a little huddle on our own. I also will see patients in clinic. I'll see patients that come in, outpatients with devices and check their devices and work in clinic. So it's a pretty global type of job. And I also manage the device equipment, what to order, when to order, managing things that expire, and do also patient management along with the doctors. Anticoagulation is really big, as is blood pressure. So I do data collection to make sure that we're keeping our anticoagulation within goal nationally, and our blood pressure in goal nationally, because the results will be best if we're able to do that.
In pediatric critical care, there are many people who work in support roles, almost behind the scenes, making a difference for children, families, and staff alike. Without them, things just wouldn't function effectively or safely.
Hi, my name is Jenna Cartlin, and I am a porter here at Victoria Hospital in London, Ontario. As a porter, I am joined by an amazing team of porters as we pride ourselves on the safety and transportation of patients throughout the hospital and the PCCU. In the Pediatric Critical Care Unit, porters are responsible for the safe transportation of patients, stats, specimens, documents, linen, equipment, and anything else that needs to go to and from the department. Porters further contribute by making family members and loved ones feel most comfortable as we push their little ones throughout the hospital. In the PCCU, we are centered on high-quality patient care as we work with the little ones in the PCCU.
Hi, my name is Roma Cordassi. I am an environmental services worker here at LHSC. I look after the cleanliness of my unit in PCCU. During the pandemic, it's become even more so important with making sure that all of our high-touch areas are disinfected. We keep all the patients and the staff safe.
Hi, I'm Alexis. I'm a unit clerk in the PCCU, Pediatric Critical Care, at London Health Sciences Center. Our role is to help to communicate needs and wants of patients and their families to our staff, as well as communicating between our unit and other units and our staff and other services. We act as a liaison between a lot of the outpatient departments and the inpatient units, just to make sure that everything is running smoothly and everyone is kind of on the same page with appointment times and bookings. We are also responsible for our staffing and scheduling of the unit, just making sure we have enough hands on deck when things get busy, as well as making sure that things are known well in advance and that our nurses are happy, which is a huge part of the role. We just like to accommodate and to make sure that our families are having the best experience that they can here at the hospital by putting them in touch with the resources that they will need during their stay, such as Ronald McDonald House or Ronald McDonald Room for a shower, and the Family Resource Center if they have any questions or any concerns.
I'm Wendy. I'm an aide in the Pediatric Critical Care Unit here in London, Ontario, Canada at London Health Science Center. My role here is to assist and help and support and work with the nursing team to make everything available to them. They have these bedside carts which I stock, and if their stock is empty, then I order it and get it delivered so we can make sure that they're up to par. I order sterile trays, gowns, isolates, all of this from our MDR department, which is downstairs. I also order nutrition to stock our fridge for the patients. And there's other checklists throughout our unit that I'm responsible for to make sure that they are stocked, they are working properly, and if not, reported to my manager. And then there's all the little jobs around to make sure that nurses have pumps, everything readily available for them to use. So that basically sums it up. There's a little kind of a go-to. If they need something, I go get it. But I'm here and we work together as a team, and it's a great experience.
Hi, I'm Jennifer Banting, and I'm a Family Resource Facilitator in the Pediatric Family Resource Center at Children's Hospital, London Health Sciences Center. As a Family Resource Facilitator, I've had a child who's traveled in and out of the hospital. This is useful as peer support when we travel to the Pediatric Critical Care Unit to visit with families. We offer a coffee, a tea, a listening ear, and that one consistent individual that the family may look to as they transition in and out of the hospital and to various floors within.